Welcome, welcome, welcome in, everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. We appreciate you taking time today to join us. If you're new to Care Concierge or Care Patrol, Care Patrol is a placement agency, and what it does is assist families and individuals who are in crisis or who are simply planning ahead to discover what care options are available to them and what would be the best option for them moving forward, what those options cost, how one qualifies. We even tour clients, much like a realtor might. So you might think of Care Patrol as something of a healthcare realtor. We are being joined today by Dr. Andrew Duxbury, who will present to us uh, Geropharmacy do's and don'ts. And I'm looking for him now. Maybe he's the iPhone. Hello, Miss Hurd. Is it humid in Montgomery? It's rainy and hot here all the time, it seems. We are accredited by the Alabama Board of Social Work. We're also accredited by the Alabama Board of nursing. Excuse me, I'm a little frazzled today trying to get Dr. Duxbury into the room, and so the only thing I know to do is to allow all of you to have your mics on and just allow Dr. Duxbury to speak. Dr. Duxbury, you may know, he's worked with us before. He is from Seattle, trained in undergraduate at Berkeley, got his UC Davis in Sacramento, got his gerontology degree, and came to UAB to join the gerontology practice here. And he is now medical director of that. He's done prolific work with the VA. He's also prolific in terms of his creative force. He is an actor who's been in Opera Birmingham, and he's written two books, the Plague Diaries, the Accidental Plague Diaries, which recount his experience and our experience during the time of COVID. And I tell you, it's so quick that we forget, I think, how frightening a time that was. And rereading, or reading rather, his real time observations was simply amazing. So I think all of you now have the ability to speak. Dr. Duxbury, if you are ready to take over.
I am here.
All right, terrific. Thank you. So I'll switch to well, let me say one thing for all of you before we get going. The CEUs are good for 1 year, I believe. That's true, Mila Wells. And you can all stay muted. Thank you, Miss Hurd. If you will please mute yourselves, that would be wonderful. Let me tell you the reason I brought up who accredits us. I want to give you the link to the evaluation, which, if you want credit, you must do the evaluation. The link today is https://www.surveymonkey.com/lowercase r/all uppercase letters and numbers, T as in Tom, J as in Julie, S as in Sam, F as in Frank, P as in Polly, 37. We give our password at the end today, and in this way, the Board of Social Work in Alabama considers this a live hour. This is also considered a clinical hour. So, Dr. Duxbury, I'll get out of the way and allow you to take over.
All right. Well, I'm here. Thank you for inviting me to speak today. And our topic is geropharmacy. And geropharmacy as a concept is that the older and aging human body may not necessarily react or interact with medications and drugs and pharmaceuticals in the same way that the younger adult body does. Although there's not a whole lot of research out there and not a whole lot of science about just what those differences are. But as someone who has now about 40 years of clinical experience in the area, I can tell you they exist. We need to kind of make some definitions so that we're all speaking on the same page. And the first one is, who's old and who are these elderly people? And I now, having been roughly 40 years in medicine, realize I am on the cusp of becoming one of them because I am less than 2 years from hitting my 65th birthday. And in terms of how the US government determines whether you are old or not in terms of healthcare, 65 is the magic line. Now, I imagine that on my 65th birthday, I probably will not feel a whole lot different than I did the day before. Most of us don't. It's not like the old age fairy comes floating down from the ceiling and you wake up all gray and wrinkled on that day. So people on the other side of that line are not necessarily a monolithic single population. They are many, many subpopulations of many different kinds of needs and types. And when we lump them all together, we do a disservice to the wide variety of folk and and their needs. Some have got physiologic needs, some have got psychosocial needs. What is true for one population may not be true for another. And aging is not new. Aging has been going on as long as we have been living in more settled society, and therefore patients have been allowed to become somewhat older in age. And this is a Renaissance painting of an older man with his grandchild. And the thoughts were probably going through his mind 600 years ago were probably not all that different from the kinds of things that a grandfather thinks of a grandson today. All right, next. All right, we are Cro-Magnons. There is no physiologic difference between us and those who were racing across the plains of Europe chasing a woolly mammoth 20 or 50,000 years ago. And the evolutionary pressures that created the Cro-Magnon species out of more primitive hominids that existed before that required for the unit of survival, which was not the individual but the tribe, that members of the tribe could live long enough to have grandchildren. You had to make sure that your children could successfully have children. As long as that could happen, the tribe could go on. So we were pressured into having lifespans of at least 40 years. After that, at 43 or 44, if the saber-toothed tiger got us, well, the tribe would go on. So this is why our bodies work so well, through our teens and 20s and 30s and into our early 40s, because all of the problems that would occur before then, natural selection has weeded most of them out, and they just aren't part of us anymore. But things that strike after that time have only really been a concern since we've lived in more settled civilization, and that's only been going on for about 6,000 years, which is not enough time to change fundamentally who we are. Next. And we have very different social attitudes now towards aging. A few generations ago, and here's a picture of the famous actress Edna Mae Oliver when she was age 56. And here's a picture of Dolly Parton today, who is now 79. The baby boom has very much, as it has moved through its life stages, redefined how we conceive of age. The lead edge of the baby boom, including Dolly Parton, including Sally Field, including Susan Sarandon, including Sylvester Stallone, including Bill Clinton, including Donald Trump, including Cher, they're all the first year of the boom, has always considered themselves the youth generation. And because their parental generation has been so long lived, they've always had parental figures above them to help them consider themselves young. Well, there's no physiologic measure by which you can consider an 80-year-old as a young person, even though that's where they are headed very quickly next. And older adults interact with the healthcare system in a very different way than younger adults do. We are just a few years from what is being called peak age. And peak age is going to happen about 2030. And it is the year in which the entire baby boom cohort will be over the age of 65, but they will not yet have begun their die off in significant numbers because the oldest folk in the baby boom in that year will be 84. So, yes, they will be dying, but, particularly in those who are visible in our society, 84, 85, most people are still kind of around and functional. Even though that cohort is 1/4 of the population or less, they use 1/3 to 40% of the total health resources, and they are by far the heaviest consumers of medication and medical equipment. And if you ask an older person as they age, how do they want to live their lives? There are very few that say, I want to move into a nursing home. They say, I want to live my life in my patterns in my home in the way I always have. We don't have a system that necessarily allows that to happen well next. So here we have a central dilemma. And as the lady says to the doctor, I feel a lot better since I ran out of those pills you gave me. The health needs of older adults are usually those of chronic disease. As we move through the life cycle, we are more and more likely to encounter a disease process that does not have a quick solution. It becomes part of who we are and just must be dealt with through the rest of our lives. It's chronic. Whereas in young people, the disease processes are more acute. They are things that happen to their bodies that can be fixed and removed, infections or injuries. And our health system, because it was based around acute care principles, because that is what was important at the time we were moving all of the structures into place, are not necessarily going to deal well with chronic disease. And our use of medications is usually fixated in acute care thinking. Here, take this pill, you'll get better. But that's not necessarily what happens, particularly in older adults. Next. So medications are one of the two top most pressing issues in elder health. There's one thing I've learned in many decades in geriatric care is the two things where I can make the most inroads and save the most heartbreak are getting the medicines right and keeping people off the floor. The reason medications are such a pressing issue is that we tend to believe in the power of the pill. If one pill is good, five is fantastic. So there is a cultural push to the overuse of medication. The medical system has a very strong distrust of discontinuing medications. It's very good at adding them. It is terrible at taking them away. There were some great experiments done a number of decades ago with resident physicians where if they sent their older patients out for expert geriatric consultation and then the recommendations came back, if the recommendation to the resident was that they add a medication, the resident did that somewhere between 95 and 98% of the time. If the recommendation was that a medication be stopped, the resident would do it between 30 and 40% of the time. We just aren't trained to subtract, only to add. We've had issues with information systems. Anyone of us who works in healthcare realizes that no EMR talks to any other, or no EMR talks to the billing system, or talks to the administrative systems, or it gets crazy. And all of this can have enormous consequences for individuals. Next. Back one. There we go. All right. In the US, those over 65, currently roughly 18% of the population, take about half of the prescriptions and over the counter medications. They take an average of 5 different prescription medications and 4 over the counter medications on a daily basis. And they fill an average of more than 20 different kinds of medication over the course of any given year. And that's both prescription and non prescription. There has never been a controlled study of a human body with more than 3 drugs circulating in the system at the same time. Because when you add a 4th, 5th, 6th, 7th, 8th, 9th, the variables become so complex, it is not possible to do a controlled study on people with this many circulating chemicals. Therefore, we do not know from a scientific point of view what is going on in the body of an older adult who is taking more than 3 medications. It is not medical science, it is medical art. And sometimes it's more medical Jackson Pollock than it is medical Vincent van Gogh. Next. We have in our society a tendency to think that things that we can buy without a prescription are harmless. And this is not necessarily true. It is just that the FDA has determined that this product is either not likely to kill you or is not a quote drug unquote. It is a food supplement. And supplements are not subject to the same kind of rigorous testing and safety protocols that drugs are. And this is why when supplements are advertised, they always have to give that disclaimer of not intended to, to treat or cure any disease, blah, 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 because it's not a drug and not tested in that way. And this is all exists because the manufacturers of such products got together in the early 80s and went to Congress and made sure that the rules were rewritten in their favor. There are things that you can buy over the counter that are just as dangerous as prescription medications. Here's a common example: Benadryl or diphenhydramine, which is pretty much the active ingredient in almost anything that is sold over the counter that says it helps induce sleep. Benadryl in young people was relatively harmless. It may make them a little sleepy or stupid, but no particular problems. In older adults, it can mimic the signs and symptoms of dementia. And there's even some evidence that's coming out that it can cause Alzheimer's type dementia if used on a routine basis. But people still, quaff their Tylenol PM on a regular basis. We often don't even ask people about what they use over the counter because physicians are trained that that's really not medication. So why do we need to know about it? And there's not a lot of great information out there about what's in a lot of these products. I look in what's called the herbal PDR at times when somebody comes in with a bottle of something I have never heard of. The Poison Control Center can be useful if someone has weird symptoms and they have ordered something from overseas. And it may have a really strange name that makes sense in the country of origin, but is not familiar to the US medical system. And I find that pharmacists are my best friend a lot of the time in terms of researching and finding out just what's going on with people. So While I never argue with success, if someone takes something over the counter and it helps them and it makes them feel better, great. I also caution people and say, we just don't know all that much about what these products are or do. And there is no rules from the FDA that says that what is on the label and what is inside the bottle have anything to do with each other. Next. Adverse drug reactions are pretty common. And when it's been studied, something like 10 to 20% of hospital admissions in adults over 65 are based in an adverse drug reaction of some sort. There's been a problem with an anticoagulant and there is a bleeding issue. They're on anti-diabetic medication and they have a hypoglycemic episode. They become confused because of whatever cocktail of centrally acting agents they may be using. There was an accidental overdose of some sort. This means that it is more common for an older adult to present to the hospital with an adverse drug reaction than with coronary artery disease. And we think of coronary artery disease as happening all the time, but we tend not to think of adverse drug reactions being everyday occurrence, but they are. And somewhere around 1 in 3 hospitalized elders will have something happen during the hospitalization that should not because of a medication issue of some sort. And these run the gamut. And the majority of them are relatively, oops, we shouldn't have done that types, but sometimes they kill people. One of the most common ones is that the list of medications in the chart has nothing to do with what the patient has actually been doing at home. And when they are admitted, what are they given? They are given what is in the chart. Next. Now, we have more adverse drug reactions in older people because what's called the therapeutic window, the level at which the drug provides its beneficial effect without having its negative effects, narrows. It becomes harder and harder to hit it just right. And this is because of the physiologic changes of the aging body. And because it becomes harder and harder to hit it just right, a lot of times older adults need lower dosing than the standard adult dosing for common medications. But they're usually just put on the standard adult dosing, or they were put on the standard adult dosing 30 years ago and no one has ever looked at it to change it. A really common one that I've seen a lot is people who were put on digoxin in prior years and just left on it become digtoxic as their body changes, and nobody has ever bothered to check a level to see, what's actually going on with that dosing as their body has changed. Next. So what are the risk factors for adverse drug reactions? Your age is actually not a risk factor. It's conditions that will travel along with age that can do it, but just the number itself is not a problem. So what kinds of changes that travel with aging can be problems? Changes in cognition. If your cognition is not working well, you may not remember to take your pills. You may accidentally take them twice in a day. You may not remember to refill them. You may not store them properly. I see a lot of people who will get into their pill boxes when they have cognitive problems and they'll play around and they'll put all the blue ones in one tray and then they take them all at once. Changes in physical functioning. If you are having difficulties getting around, getting to the pharmacy may be an issue. And therefore, people do not refill as well or as regularly as they should. Side effect profiles. If people figure out that something they are putting into their bodies is making them feel worse, they usually stop doing it. But they do not necessarily tell their prescribing physician that they have stopped doing this. And so there may be a belief on the part of the medical system that this is happening, whereas something else entire is happening at home. The more medications and the more complex the regimen, the less likely someone is going to be able to adhere to it properly. No human being in the community takes drugs routinely more than twice a day. In order to get anybody to adhere to a 3 or 4 time a day regimen on a routine basis, there better be a paid person in the mix somewhere whose job it is to make sure that that is happening. Normal people can't do it. Normal people can take their morning medicines pretty regularly because our morning patterns are usually very similar day to day. People do not take their evening medicines routinely because our evening patterns can be all over the map depending on what we did that day. So always put the more important stuff in the morning. Of course, the number of prescribing physicians, because somebody is not paying attention or does not know what somebody else is. The number of filling pharmacies. Pharmacies, now that everything is computerized, are very good at catching problems and letting people know, but they have to be filling every medication to be able to catch those things. Child-proof caps. They require children to open. Old arthritic fingers cannot. And all the economic issues in regards to cost. If you can't afford it, you will not take it. Next. There are problems with understanding adverse drug reactions because, one, we do not study them in older people. In order to study drug reactions, we need to have a nice, clean sample of individuals without conflicting disease processes or other medications. And finding that kind of population in older age is very, very difficult. So elderly are usually fairly systematically excluded from drug studies. And this leads to problems because the drugs which are tested in a fairly healthy cohort are then released for general consumption. And who starts taking them on a more regular basis? Older people with lots of problems. And then we have issues like what happened with Vioxx and Bextra about 20 years ago. There can be very different pharmacokinetics in an older body than a younger one in terms of how drugs are processed, excreted, and metabolized. There's not, as I said, controlled research on humans with multiple medications circulating. There are genetic factors. One of the dirty little secrets of the pharmacy industry, which they know well, is that any one of their products will not work in somewhere between 10 and 30% of the people to whom it is prescribed because of genetic differences. And we don't research drug use or kind of chronic medication use in chronically or ill individuals because that it becomes too hard. Is this problem due to the underlying illness or is it due to the drug? It cannot easily be teased out. Next. So what kinds of things do adverse drug reactions cause? Confusion is a big one, and delirium, which is not the same as dementia. Dementia is a chronic process that sneaks up on someone over months to years. Delirium is an acute illness that happens very, very quickly. Somebody who comes in very confused or becomes confused in the hospital who was fine outside the hospital, that cannot be diagnosed as new Alzheimer's onset or dementia. That is a delirium. Dizziness, falls, problems with appetite and therefore weight loss, depression, continence issues, constipation. These are some of the major ones. Next. What kinds of medications can cause confusion? Anticholinergics are big. And diphenhydramine Benadryl, which I mentioned earlier, is an anticholinergic because acetylcholine is the neurotransmitter most involved in memory. And anything that blocks its action can affect memory, particularly in an older brain where the capacity to deal with information is just already reduced from other aging changes. Alpha agonists, these are drugs like clonidine, dopaminergic drugs that are involved with Parkinsonian syndromes of one kind or another, benzodiazepines, which are also very high risk for falls, H2 blockers. The one that's most concerning is cimetidine, which for the most part is not used in this day and age. Everybody pretty much uses famotidine, which is far less of a problem. Non-steroidals in some individuals, depending on genetic makeup, sulfa drugs, and beta blockers. Next. Medications linked to falls, it's usually one of two reasons. One is cardiovascular, in that blood pressure is lowered, or the ability to pump blood through the brain is not as well because of changes in the heart. And what kinds of things can do this? Antihypertensives, anything that will be blood pressure, diuretics, which reduce volume, nitrates, which vasodilate, antiarrhythmics, which may slow the heart in some way. And there are, as we go along, we're finding more and more drugs that are causing issues with heart rhythm due to prolongation of QT intervals in that had not been suspected as being culprits in the past. A big one is donepezil or Aricept, which is used in dementia. It's becoming more and more problematic to use that one in anybody who has underlying heart conditions because of issues with heart rhythm that it can cause. Or there is a neurologic issue from the drug in that the brain and the nervous system that allows us to maintain posture are not communicating in the way that they should. Anticholinergics again, anti-nauseants, non-steroidal, they're all about not being able to get the messages from the 250 muscles involved in posture and balance to the brain, have the brain sort through them and send the messages back to those 250 muscles to constantly adjust. Next. Medications linked to anorexia and not wanting to eat. Digoxin, particularly an overdose, is a big one. A lot of the antiarrhythmics of various stripes can cause problems with appetite. Opiates make people just not want to do much of anything, and eating is one of them. Iron, potassium can have direct effects on the GI tract to just make people feel uncomfortable and therefore not wanting to eat. Laxatives, because of just their changes in bowel and habits. And the gut has its own nervous system completely independent of our central nervous system. And when something is going on with the bowel, it communicates back with the stomach and back and forth, and it can send messages that you cannot control. And if one piece is not happy, other pieces often become unhappy. The SSRIs tend to decrease appetite. Our old friend, the anticholinergics again, decongestants, things like Sudafed and amphetamine type drugs. Next. Things that can cause depression. Beta blockers is a big one. Alcohol. We tend not to think of alcohol as a medication, but somewhere around 5 to 10% of the population self-medicates with alcohol in some way, shape, or form. And you gotta be suspicious and think about it. The little old lady who has been falling a lot comes in with the hip fracture and gets it repaired. If she starts going wild on hospital day number 3, she may be alcohol withdrawing because she's a closet drinker, and that's why she was falling over to begin with. Benzodiazepines, alpha agonists, these all affect how the brain talks to itself and the amount of neurotransmitters available. Next. Incontinence. These are things which either change the amount of volume of fluid that have to go through the bladder and increase it beyond the bladder's capacity, or monkey with the chemical abilities for us to keep our sphincters closed and under our control. And both alpha and beta and calcium channel blockers are all involved in keeping our voluntary and our involuntary urinary sphincters closed, and in the allowing of the detrusor muscle to relax so that we can continue to hold things in the bladder. Diuretics are involved in volume, of course. Sedatives, that's a problem because if you are asleep and your message of I need to pee is not capable of waking you up out of that sleep, you're going to pee the bed. Next. Constipation. Opiates are classic, of course, and no matter how long someone takes opiates, they never become habituated in terms of the constipation side effects. It is a chronic problem from day one through day infinity and always must be thought about. And anybody that is on chronic opiates, bowel habits and bowel regimen need to be thought about, because if you go 2 weeks without pooping, you will all be in trouble. Iron can constipate. Fiber supplements, certain ones can kind of turn the bowel contents into cement, and you have to kind of watch for that. Anticholinergics, H2 blockers, and proton pump inhibitors, because of the talking back and forth of the various pieces of the gut to each other through their automatic nervous system. All of that can cause issues at times. Next. So what kinds of things are usually overused? We overuse opioids. We have 5% of the population of the world in this country, and we use 50% of the opioids produced. So we'll probably use a lot more than we need to. Non-steroidals, which can be problematic in older people. They can cause significant GI problems, and they can cause significant renal problems, particularly in people over the age of 75 or 80. We use a lot of anti-anxiety medications. We have created a society which is barely fit for humans to live in, and lots of people have got mental health issues because of this. And we believe that the way of handling that is the power of the pill, because we don't give a lot of other alternatives that those without major resources can possibly afford. Next. Drugs don't work in patients who don't take them. I always like that line of Dr. Coops. Next. So we want to have medication adherence. What is medication adherence? We used to talk about medication compliance, but in the professional world, we've kind of tried to get rid of that compliance, which assumes that all of the factors and the reason people aren't taking pills is all on them. And medication adherence broadens it out to say, no, this is more complicated than that. The issue may not just be them. Next. So we have to look at ourselves, and we have to look at the system and society as a whole, and not just this paternalistic is it's all up to the patient. And adherence suggests that there's a partnership going on between a patient and a provider, and that a good provider is going to know who their patient is, what their social structures are like, what their limitations would be, what their economic resources are, and has to take that into account when thinking through how do I use medications next. There's about 125,000 deaths a year in this country because of medication adherence issues. Usually people not taking what they've been prescribed because they're not getting it for whatever reason. About a quarter of the people who are placed in nursing homes are placed ultimately because they're not capable of adhering to medication regimens in the home, whether that's they themselves or family or just lack of supports. And about 10% of hospital admissions are due to medication adherence. Next. So how often are medications actually taken correctly? There's a rule of three. About 1/3 of medications are taken correctly. Another third are taken but not correctly. And the last third aren't taken. So there's about 2 billion prescriptions written in the US every year. About half of them are not taken right. And somewhere between 15 and 25% are never filled. Next. So medication adherence is multi-dimensional. There's a lot of things that we need to think about in terms of, and this particular model says that there are 5 domains of adherence. Next. social and economic. Can this person get to the pharmacy? Because most of us do not have a pharmacy in our kitchen. What are the costs? Are there caregivers available? Do they have insurance or anything that is going to make expensive pharmaceuticals a realistic option? Next. The system. Again, is the pharmacy available? Is a physician available? Most of us have noticed that primary care physicians are becoming less and less available because fewer and fewer American trained physicians are choosing any kind of primary care specialty. And the reasons for that are very complex. There has been a rise in nurse practitioners to try to make up the difference, but it's not really keeping up. In the past, legibility of the prescriptions was an issue. With electronic prescribing systems and that's usually been solved. How accuracy of the medication profile is. I teach my medical students that there are always three medication lists. There's the one that the doctor is carrying around in their head and they think that they should be doing. There's the one that is actually written down in the medical record. And there's what the patient actually does at home. Those three things are usually very different from each other. And a big piece of the job is trying to get those three things lined up and reading vaguely the same. How well things are labeled so people can understand them and whether or not they can tell their pills. I can't tell you how many times when people will call and say, I need more of my little white pills. Okay. I can't help that. Next. Condition-related factors, physical and cognitive functioning of all sorts. Nausea or GI issues. If you don't feel well, you're not going to put more pills on top of not feeling well. Pain, fatigue, depression, all of these are going to change how we relate to our healthcare and our medications. Next. Therapy. Side effects. As I said, people who know they have side effects often stop taking or reduce doses or do something, but not necessarily let anybody know that's what they're doing. The dosing regimens and how complex they are, the size of the pills, little teeny tiny pills that you can barely see are a problem because old eyes and fingers can't deal with them. And great big horse pills are a problem because people can't swallow them. Next. Patient-related factors. Is this person literate? Are they health literate? What are the cultural norms in regards to healthcare and medications for this person and this family? What kind of belief system might they have? Who are they? All of these kinds of things can greatly impact what will be an optimal medication regimen. Next. Well, so there's been a big push over the last decade or so towards what we call medication reconciliation, which is, can we get those three lists that I talked about so that they all read the same? There was a think tank about 25 years ago who put out what they called the never events list. It was a list of 28 things that they should never happen in a modern healthcare system. And one of those things was people should never be given the wrong medication. Next. Now, there should not be a death or serious disability associated with medication error. That we should never have a death or disability because of being given the wrong blood product or blood type. And we should not ever have an issue with people having a serious problem with hypoglycemia, meaning they were given excess diabetic medication in some way. That if they're in a hospital or a nursing home or someplace where people are watching, it shouldn't happen. Does it happen? Of course. Next. So what kinds of things can we do to help? Well, it's been studied over and over again. No one's come up with a magic bullet, but there's all sorts of ways of organizing and reminding people about pills. Some are cheap, some are very expensive. None of them has ever been proven in a study to be more effective than any other. Next. Medication lists, we all keep them. Some of us scribble them down. Some of us have apps or computers or things for it. Next. There's all sorts of proprietary things out there. If you still use like a Covey system, I mean, they'll sell you one that'll help keep track of your medications. All of these things. Next. Next. What is that? We seem to have skipped ahead. Yep, press that. Press that.
Next down. There we are.
No, next.
Events.
We're about 3 down from there.
Okay.
We're gonna keep going. There, next one.
I'm so sorry.
There we are.
One more?
No, that's where we are.
Okay.
All right. Pillboxes, they range from the very simple, $1.99 at Walgreens to very complicated. If you go to epill.com, they will sell you all sorts of fancy electronic, and the little drawer pops out and goes ding, and it will Bluetooth call your daughter. If you don't take it, hit the button. But every family has to kind of figure out what works for them. That was the next one. Yeah. Okay. Subpopulations. For the visually impaired, you can actually buy caps for the bottles that talk. And you can record, this is my heart medicine. You can get symbolic medication lists for people who are not literate, so that it has a picture of the pill and, when you should be taking it. Next. And then people keep talking about, can we have some sort of incentives for people to be able to take their medication? What acts as a motivator in our society that will make them more likely to do so? And are any of these things practical? Next. So, medication is candy does show up. The pediatricians hate this one because that they're always afraid that, small children in the home, we're going to go yum yum and start chowing down on Mama's digoxin. But some of the over the counters, I mean, we are all familiar with gummy this and gummy that these days. Next. Medication is a status symbol in some way, shape, or form. And, selling the capsule coatings for brand, my pills are by Versace, kind of thing. No one's seriously been approaching this one yet. Next. Monetary rewards, but we all know what would happen for this one is that people would just punch them all out at once and redeem. So that's probably not practical. Next. So some basic principles for prescribing, that if you are on multiple medications, that you have a primary care physician who is not necessarily a primary care specialist. If all of your problems are in a single organ system, the specialist for that organ system can act as your primary care physician. But that you should have one kind of main brain that knows your medication list and how you use it, and who kind of is the person who makes a decision as to whether this medication or that is appropriate and when adjustments should be made. Make sure that documentation is correct and up to date. that medications are always looked at and selected to try to avoid things that cause adverse drug reactions and things of this kind, and make sure that dosing is appropriate for older individuals, meaning that usual starting doses are a quarter to a half of what we might consider usual standard adult doses. Next. So our take-home lessons of the day: that we need to treat medications with healthy respect. The way that I do this is I have to keep reminding myself that medications are controlled doses of poisons. What does a poison do? A poison enters the body and physiologically alters things in a not very nice way. What is a medication? It is a substance that physiologically enters the body and physiologically alters things, but hopefully in a good way. But if too much of it is there, it often does it in a not very nice way. Medication use discussions should be based on objective evidence and what we know from science, not on whatever is on TV or what Dr. Oz says, or whatever the latest commercial that runs late night is claiming. And we need to make our decisions based not on the chronologic age of a patient, but more on their physiologic and functional issues and age. And that, just because someone is 80, no two 80-year-olds are alike. You met one, you met one. All right. And that's the end of the prepared remarks.
Thank you so much. If anyone has questions for Dr. Duxbury, we have a few moments. I've listed our password on the screen, which is Geropharmacy with a capital G, all lowercase Geropharmacy. Geropharmacy is the password. The link is https://www.surveymonkey.com/lowercase r/ all uppercase letters with numbers, T as in Tom, J as in Julie, S as in Sally, F as in Frank, P as in Polly, 3-7. Thank you so much, Dr. Duxbury. I know you took time out of clinic to do this, and I appreciate it. It was so informative. Julie Cox is asking, what is the best way for ologists, in quotes, to look at medication prescribed by other physicians and communicate? My dad has so many doctors, and they don't seem to consider what the other specialists are doing.
Welcome to reality. You keep the list, you keep it updated, say this is what he is doing at home. Please look at this entire list and make sure that there is nothing here that bothers you.
And that may be it for our questions, Dr. Duxbury. I'm so indebted to you for doing this. I so much appreciate it. It was excellent. And I hope that the folks who are on today, if any of you are new or not new, join us again on Monday, August 11th, when Ashley Limsky of the United Way will tell us about all of the services offered by the area agencies on aging. So that will be a wealth of information as well. Thanks to Dr. Duxbury. Thanks to all of you for being here and for choosing to spend your time with us and for the work that you do when you're not with us. I hope everyone has an excellent week or 2 weeks, and hope to see you again in August. Thank you so much.
Been my pleasure.
All right. Let's see if I can end this thing now. Let's see. How do I? There we go. Thanks, everyone.